Hello and welcome to the COMLEX Instant Podcast. Please visit comlexflashcards.com for additional board review podcasts and lectures. Let's talk about Bartter syndrome. Bartter syndrome is a condition where the kidney has disease, and that leads to sodium, potassium, and chloride wasting. And so there is, the wasting of these electrolytes despite increased levels of renin, and the blood pressure here remains low. That's the key point. If you see Barter's on the test, think about wasting of sodium, potassium, and chloride, increased levels of renin, but low blood pressure. That's the key sign that you want to remember. Next, I want to talk about Charcot-Marie-Tooth disease, a very high yield topic that you may encounter on the boards. It is autosomal dominant, and there is peroneal muscular atrophy, causing the most typical symptom of foot drop and stalk glowing decrease in vibration and pain and temperature sense and deep tendon reflexes where in the lower extremities. Okay, so the two things here, foot drop and the loss of vibration, pain, temperature, and DTRs in the lower extremities. It's autosomal dominant, and on histology you see repeated demyelination and remyelination of the segmental areas of the nerve. Patients may present as children, which is usually considered to be Charcot-Marie-Tooth type 1, or patients will present as adults where you have Charcot-Marie-Tooth type 2. Next, I want to talk about Caisson's disease. Well, this is also called the bends, and again, this is a decompression sickness that's caused by rapid ascent from the deep sea diving. So that's a classic board review scenario that you may see. The symptoms usually occur from 30 minutes to 1 hour, and patients have joint pain, cough, skin burning, and those are the three things you want to remember, along with the history of deep sea diving. Next, I would like to talk about Caroli's disease. Caroli's disease is a condition where patients have the cystic dilation of the intrahepatic bile ducts, and that's usually complicated with stones and cholangitis. And also, the worst thing is that this could be a precursor to cancer. So with Caroli's disease, think about intrahepatic bile ducts with stones and cholangitis. Stones, cholangitis, and intrahepatic bile duct dilation. The reason why this is important to know is because you can confuse this with other conditions such as PBC or any other condition which can have dilation of the hepatic bile ducts. And again, keep in mind it's a precursor to cancer. Next, I would like to talk about Chidiac-Higashi syndrome, which is an autosomal defect, usually of the microtubule functions of the neutrophils. That's, a key word there. It leads to decreased lysosomal fusion to the phagosomes, and it presents with recurrent staph and strep infections with, these are the key points you want to remember: albinism, peripheral and cranial neuropathies. So patients who present with Chidiac-Higashi have autosomal recessive, they have microtubule function defect of the neutrophil specifically, and also decreased lysosomal fusion of the phagosomes. Finally, they have recurrent staph strep infections with albinism, peripheral and cranial neuropathies. I want to talk about Beckwith-Wiedemann syndrome. This is a autosomal dominant condition where patients present with microcephaly, microglossia, organomegaly, omphalocele, and a distinctive lateral earlobe fissure. This board exam can definitely show you a question with these easily laid out, and you'd have to pick the right syndrome. The key to remembering Beckwith-Wiedemann syndrome is that there's an increased incidence of Wilms tumor. Also, patients have hyperinsulinemia, and so patients will present with hypoglycemia because of the high insulin. So let's review some of the key points for Beckwith-Wiedemann syndrome. Increased incidence of Wilms tumor. When you see the patient, they can have macrosomia, microcephaly, macroglossia, organomegaly, omphalocele, and a distinctive lateral earlobe fissure along with hypoglycemia. Okay. Now let's review Bernard-Solier syndrome. This is an autosomal defect of the platelet GP1B receptor, and it binds to the von Willebrand factor. Okay, so what does it present with? Well, chronic severe mucosal bleeds and giant platelets on blood smear. So if you see giant platelets on blood smear and you're thinking of a condition with severe mucosal bleeds, you want to associate this with Bernard-Solier, and if they ask you what's the cause, well, it's a defect of the platelet GP1B receptor. Finally, I want to talk about Binswanger's disease, which is a subacute subcortical dementia. Keyword there, dementia. And it's caused by small artery infarcts. So the infarcts are due to, most likely, long-standing hypertension. And again, patients have periventricular white matter formation that you can see. Now, let's talk about Cheney-Stokes respiration. Well, this usually causes central apnea, which is seen in congestive heart failure. Okay, so you have apnea in CHF patient with increased intracranial pressure or cerebral infection or inflammation. Patients will generally have conditions where you see regular crescendo decrescendo breathing. A key point there. Regular crescendo decrescendo breathing. And what I mean by that is that the amplitude first waxes and then it wanes back to the apnea. Okay? Also, Biot's is an uncommon variant seen in meningitis in which the cycles consist of central apnea followed by steady amplitude breathing that shuts back off to the apnea. So here's a lot of important points that you want to remember for the board exam. Any scenario where a patient has CHF plus apnea, immediately think of Cheney-Stokes respiration. Then you're thinking, well, what is it caused by? Well, is it an infection, a cerebral infection or inflammation? And then you want to look for the cycles of their apnea. Is it crescendo decrescendo breathing? And then there's cycles of central apnea. Again, if the patient has meningitis, Biot's is a uncommon variant of that. Now let's talk about another condition known as chronic granulomatous disease. And for chronic granulomatous disease, the key words are NADPH oxidase deficiency and a lack of respiratory burst. So you can engulf bacteria, but you're unable to actually kill them. That's the key point here. And how does it present? Well, the association with Aspergillus is a key point here. Aspergillus and Staph aureus both present with recurrent infections in patients who have chronic granulomatous disease. And the treatment is going to be recombinant interferon that's going to help the patients. But again, the key points, Aspergillus with recurrent infections or Staph with recurrent infections, and you have a feeling that this is causing a deficiency in their immune state. You're thinking NADPH oxidase problem or lack of that respiratory burst, and the treatment is going to be recombinant interferon gamma as the choice on the board exam. Finally, I want to talk about Bruton's agammaglobulinemia. This is mainly a patient who comes in, usually an infant greater than 6 months age, and they have recurrent bacterial infections. It's X-linked, and what happens is that the B cell maturation process is kind of stalled here, and so there's decreased in B cell levels. So the B cells is a key thing you want to remember for Bruton's agammaglobulinemia. They're low in this condition, and if you see an infant with that bacterial infections along with a low B cell count, that's going to be most likely your answer choice. Please visit COMLEXFlashcards.com for additional podcasts and COMLEX board review material, and good luck in your board review preparation.